from National Association of Palliative Care for Ayush and Integrative Medicine, an organization in association with Department of Global Communications of United Nations. I am Dr. Piyush Gupta, Secretary of NAPCAM, as well as Secretary of Cancer Aid Society, which is having a special consultative status with United Nations Economic and Social Council. And together we have our colleagues from National Association of Palliative Care for Ayush and Integrative Medicine, Mr. K. Radhakrishna Menon, Dr. K. L. Babu, and Madam Malak Viri. So I would request Mr. K. Radhakrishna Menon to kindly introduce himself.
Good evening. I must first of all congratulate the students who have enrolled for the course, for the foundation course being taken up by the NPTEL and NAPCA in joint venture. This is a very good course, and every student will understand the depth of depth of understanding, the learning new knowledge in the field of science and palliative care. And personally speaking, I am K. Radhakrishna Menon, National Vice President of NAPCAM. I had been to palliative care way back in 1997, working in different capacities in the state of Kerala. And in Kerala, as all of you may be aware, palliative care is volunteer driven, and we have a very good volunteer strength. And nearly 900 palliative care centers are working across the state. Thank you.
Dr. Babu, can you introduce yourself?
Yes, I am Dr. K. L. Babu, former Principal and Professor, Government Homeopathic Medical College, Kozhikode, Kerala. And I am the Assistant Vice President of NAPCAM, that National Association of Palliative Care in Ayush and Integrative Medicine. Actually, I have 22 years of experience in palliative care. And I was the former project director of Shore of Solace, a project on palliative care and pain management with homeopathic medication. It was a project of Government of Kerala. And I had more than 20 years of experience. Still I am working with this association.
Thank you, Dr. Babu. And Dr. Malak, can you please introduce yourself?
Yes, thank you, Dr. Piyush Gupta. I am here, Malarudi K. Natarajan. I am the Principal, College of Nursing from Bangalore, Karnataka, and I also deal with palliative care because one of my family members was affected, and that has motivated me, and I have joined NAPCAM as a Vice President, Karnataka State Branch. And also I have done my doctorate in breast cancer related lymphedema, wherein I am practicing the management of lymphedema, both cancer related and non-cancer related lymphedema patients. So that is my passion, and at present I am continuing with curriculum also, being in the academic side for more than 25 years. Thank you, sir.
Thank you, Dr. Malak. And maybe Dr. Malak, do you have a carry home message for the students?
Yes, sir. As I said, I was being motivated because one of my family member was affected. Everyone has the same history, and that motivates. If you're not having in your family, I think one of your friend or a neighbor will be motivating for you. That's why you're here. If you wanted to continue with the foundation course, I think this basic course is going to help you because it has loads of knowledge and practical aspects which will develop the skill what you wanted to independently and confidently take care of the patients, especially in the home care setting, without any supervision, where you are going to lead and be advocacy for the patients who are dependent on you.
Thank you, Dr. Malak. So as we all know that palliative care has 4 major components. One is physical, to address the sufferings, treat it, maybe using modern medicine or Ayush. Then we have psychological component, because many of these patients are withdrawn and in severe depression. So how to handle them again requires skills. Then comes the social component, where the society's interaction with the patient and the patient's interaction with the society. Again, it is two-way traffic, and we have to again work on it to restore it, because the patient is totally withdrawn and socially non-interactive. So finally, the spiritual concerns are there which need to be addressed because many of these patients are going to die very soon, being terminally ill. And redressing those concerns again by not only improving the quality of life but also improving the quality of death, cutting down the cost of death. It is very important not only for the patient but for the entire family, because right now the trend is that cost of death is increasing day by day, and while the patient dies, the family comes on the verge of financial breakdown. So again, Mr. Menon, do you have a carry home message to our students?
I had a very rare experience of interacting with a patient who had a debilitating illness. She was having kidney failure, renal failure. So I connected her with doctors who are already in the palliative care profession and gave her medication and all that, but still the pain continued. So she asked me, "Sir, can you kill me? Can you kill me?" That is the question she asked me. So in palliative care, we do not wish to kill patient. We just understand the underlying factor behind. There may be a reason behind every suggestion or a question that is being put forth by the patients and the family members. So I asked her, why you said so? Why you asked to kill you? So she said, I am having a very excruciating pain. So pain is the reason for her, such words coming from a patient. So I was in a very precarious condition. I could not make a reply at that point of time. I just paused a while and asked her, if that pain is the reason, there are facilities in palliative care. Your pain can be reduced to a substantial extent. I will connect with physicians who are already in the profession. So after connecting those physicians, morphine and other medicines were given to her and she consumed. After a few days I visited her and she said, "Sir, I am getting some sort of a relief." So that is what palliative care intends to do with patients who are having life-limiting illnesses. That is a very rare experience I had, and I could not even now I could not withstand that particular situation. I pray Almighty that such situation should not occur in any of your human lives. That is a message I would like to share with you.
Thank you, Mr. Menon. And with you, I remember a case recently which was hospitalized in one of the tertiary care hospitals. It was a liver sepsis patient, almost 78 years old, and she was not responding to any of the antiemetics being given, and she was also having breathing issues and she was on oxygen. So basically all of us had left hope, but finally a few drops of homeopathic medicines made a dramatic change and almost she was discharged after a single day. So Dr. Babu, my question to you is, do you have anything in Ayush when we don't have a remedy for any symptom which is not working in case of the patient? Of modern, any of the modern medicines, they fail to work. So do you have medicines in Ayush, and are you really prepared to introduce Ayush medicines to the palliative care patients?
Definitely. This with my experience of 20 years, I have come across with a lot of patients. This pain management is also possible without this opium or this morphine derivatives, and we are giving more importance to total care of the patient. In that case, that those who are with this dysphagia, that that difficulty to swallow something, and there is painful swallowing or like that, we can manage the patient with the homeopathic medication. And even in certain cases, the patient are coming with this Ryle's tube now to feed themselves, and we can gradually withdraw the Ryle's tube and we can put on the patient on oral feeding after medication. Like that, we can improve the quality of life of the patient with homeopathic medication. Don't think that this palliative care is the end stage of the disease, and we have to give certain relief to the patient with the homeopathic medicine, and there are other systems also that they can also, and we can combine all these things and we can give relief to the patient. So lot of experience I have, and the patients are getting relief out of all these things. All the better thing is that we can improve the quality of life of the patient with the homeopathic medication, because once the patient is under this morphine or this other this sedatives, they are always under sedation. They cannot communicate with the society, the family members. So what we are doing, we gradually withdraw these sedatives, it's opium or whatever it may be, and gradually put out the patient under homeopathic medication. They can survive very well, they can communicate with the family, they can communicate with the society. It's a very good thing.
Thank you, Dr. Babu. And Mr. Menon, since you are National Vice President and you are involved in training and content development and other issues in palliative care, so are you targeting only homeopathy or other Ayush streams in palliative care?
Yes, sir. If some system of medicine which can give relief, we always welcome. There is no point of a particular system of medicine alone can do palliative care is a question to be discussed among ourselves, and I am fully I strongly believe that any system or modality or healing practices which can give relief to the patient can be taken into account.
Great. So my question to Dr. Babu is that many a times, because let's say personally many people believe that homeopathy does not act fast, and whereas these patients are in immediate need of relief, and you are giving, for example, they are suffering from multiple issues, whereas we normally give only a single remedy for treating. So what happens to other issues, and would you like to say something on this particular aspect? How you are going to use homeopathic medicines in palliative care, and will we be addressing all the sufferings of the patients, or they still have to suffer for a few days or weeks and then homeopathic medicine will start working?
That in palliative care we have to address the main complaint of the patient, the main symptom of the patient. So at that stage, we are giving certain medicines which will relieve the major important symptom of the patient or the suffering of the patient. And only after that we will give medicine which will cover the whole disease of the patient and the disease condition. So in the early stage, we will address the most distressing symptom of the patient. So for example, if he is having vomiting or she is having vomiting, we will give medicines to relieve the vomiting. Then only after that, she can or he can take some food. So after that, we will give medicine to the disease proper. So like that we can manage.
Okay, so that means you can give multiple medicines for multiple symptoms at a time.
Yeah, that we can change the medicine. Because this at one time this vomiting may be the most distressing symptom. The next time some pain or something like that. So we have to change the medicine.
Okay. So my friends, you don't have to worry. Along with the allopathic treatment, you can go towards Ayush also, because they are going to work together and help you in this. So Dr. Malla, would you like to add something?
Yes. You were all listening to all the experts here talking about homeopathy, then how to just take the professional help as a volunteer. Now I wanted to put forth what I am actually doing with my patients. I deal with patients who are having lymphedema. Now, what is the role of a nurse here? She is coming across patients every now and then, and me being in the teaching line, I can teach my students in preventive and management aspect. Now, this lymphedema can be cancer related or non-cancer related. Non-cancer related is primary lymphedema or due to any genetic problem which we don't have a control over that. Whereas cancer-related lymphedema, we know that when the patient is undergoing or diagnosed with cancer, he or she will be knowing that this is the stage I am in. The diagnosis time, if nurses or any healthcare professionals who is approaching that patient or preparing for the surgery is being taught what is it they are going to expect after the surgery. The removal of tumor, along with that the removal of lymph nodes. We can just stop the development of lymphedema. This we have trying through research and it is working out well because there are many modalities. It's I don't know how to explain it. It is the techniques what we are all following. One is that bandaging system, manual lymphatic drainage, skin care and exercises. These all put together as collectively along with nutrition helps the people to overcome this condition because the patients they don't know what to do. Pain again is due to the heaviness what they are having in their extremities and at the same time the body image is affected. As Dr. Piyush rightly said that we have physical problem, we have psychological problem, we have spiritual problem and we have social problem. Here you can see that the image, body image plays a major role especially for the females. So we have to overcome that by supporting them in preventive aspects and also promotion and maintain them also. So I think you all, if you don't bother what profession we are, but if we learn, we can help our patients. I think this is the take-home message I can tell. The maximum knowledge we can gain and what the best we can do, we can help our patients.
Thank you, Dr. Malla. So now we have learned about body image, and that is something which is again very important because most of the time when we are dealing with the patients, the caregivers are not sensitive towards the body image or their privacy issues, which affect their psychological well-being. So remember, like us, if the patient is not active, then we have to maintain their body image, their dressing, clothing and grooming. We cannot neglect the patients and whatever their needs are, even privacy issues, they are very important because normally if there are too many meetings, we may put the patient in the drawing room rather than the private bedroom. So all those issues have to be taken care of. So Mr. Menon, you are a volunteer and do you have a message for the volunteers? What is volunteering and how does it help in palliative care? What are the national trends?
You see, palliative care is teamwork. Actually, it is a combination of professionals, doctors, nurses, volunteers, social workers, carers, chaplains, and all. It's a teamwork of varied segments of the community. The community itself should come up to take care of the patient who is on the dying bed. So in that way, thinking in that way, I believe that it's a teamwork and all the professionals jointly put some effort so that the quality of life as well as the quality of death of a patient is taken into account. That is one point. Another point is that even after the death of the patient, we give bereavement support. We think that after the death of the patient, palliative care is nowhere there, but it is not. It is also part of palliative care that rehabilitation is a major chunk of the palliative care activity. Suppose if a patient dies all on a sudden, or when we think that the patient is about to die, the family members, especially the children, the wife, who are not breadwinners and all that, maybe the patient alone may be the breadwinner. When he is on the lying bed, their daily routine will be affected seriously. So the volunteers and the team as a whole will have to take the burden of taking care of the whole family. Their renovation or rehabilitation is another major component in palliative care, which is easily neglected, but it has to be taken into account very seriously. That's what.
Thank you. And what are the national trends in volunteerism?
Volunteerism, that had its roots in Kerala, I am really proud of being from that part of the country. I belong to Kerala. And apart from the northern, when we come to northern side, there are some palliative care in patchy areas, not as a whole of the state or taken by the community at large. But in Kerala, things are entirely different. Palliative care is volunteer driven in Kerala. So we take the lead in organizing seminars, awareness programs, establishing palliative care centers, giving training to the volunteers, nurses and doctors and all that, and make them skill. A skill transfer is one of the major component to be taken into account. When you are taught, then only you can teach others. So in that way thinking, human resource is the most important component in palliative care. They have to be trained in such a way that it should be beneficial to the patients and the family members of the patient.
So when we are talking about the Kerala model, so we all know that Kerala model in palliative care is famous, and maybe it exemplifies when we are talking about palliative care. So Dr. Babu, do you have Ayush integration in palliative care at Kerala or not?
Yeah. Because in Kerala, this state government, they are promoting this Ayush system in this palliative care. So that every Ayush doctor has to visit the patient once in a month. Home care is a part of their work. And now they are giving training in this palliative care. Because that I am a resource person for that also. I am going up to every district and giving, imparting training to the doctors about this palliative care. Because that now in Kerala, each and every person is aware about this palliative care. That is why in every nook and corner we can have a palliative center also. That it is run by volunteers or some organization. So that every system, that the Ayurveda, Homeopathy and Unani Siddha, that all are joined together and giving or imparting this palliative care to the patient in Kerala. That is the scenario in Kerala.
So Mr. Menon, I have come to know that palliative care is working at the level of panchayat, and it is enforced by government. So can you share the model? Why is this model not replicating? And again, to the students, you are coming from various states. Why can't you force your government to adapt the palliative care model in palliative care? So can you explain a bit about those palliative care reaching out to the level of the panchayats?
You see, the story begins in 2008, and we started our work from 2006 onwards when I was the Vice Chairman of the Indian Association of Palliative Care, Kerala chapter. We organized seminars and awareness programs, getting feedback from the people in 14 districts in the state of Kerala. So every month we go to, on Sundays, we go to a particular place in a particular district, and we organize an awareness. This is palliative care, what else can you do? Government of Kerala is proposing to have a Kerala state palliative care policy, and they have wanted a draft of the declaration to be prepared by this organization. So we drew feedback or take a message from all the people across the 14 districts, and a draft of the Kerala state palliative care policy was prepared, and that was handed over to the Chief Minister, and at that time Sri Achyutanandan was the Chief Minister. He took it and declared it as such. So the thing is that along with that, the Panchayati Raj Act was amended in 1994. You see, many times it was amended, and as a result of the amendment of the Panchayati Raj Act, the three-tier revenue administrative system came into being across the country, and that also reflected in Kerala also. So the government of Kerala decided that palliative care should be introduced in all the panchayats, or in all the three-tier administrative system. That is primary health center in the Grama Panchayat, community center in the block panchayat, and district level hospitals in the district administration. So such a system came into being on 14th April 2008. So along with that, many other changes took place, and the NRHM, National Rural Health Mission, came into being, and they also were requested to join hands with the Kerala state, and the training of professionals like doctors, nurses and volunteers took place. And now we know the system is that suppose if a patient requires homeopathic or Ayurvedic interventions in palliative care, the NRHM has a resource provision for that. They have trained doctors and trained doctors in homeopathy and Ayurveda, and it's a government policy. If a patient wants a homeopathic intervention, naturally he will be given homeopathic intervention in the state of Kerala.
Along with the modern medicine.
Yeah,
Yes.
definitely.
Okay.
That is a breakthrough achievement in the state of Kerala. And so we are getting good results out of it.
Now, Dr. Malar, my question to you is that what makes the state government not very actively working on palliative care, whereas it can reduce the healthcare cost to substantial level? When we are talking at any point of time, almost 50% of the population is suffering from pain, and this pain most of the time is untreated. So we can treat this pain, but still we are ignoring it. And when we are talking about pain, now untreated pain may lead to adding on the mental pain, because it is disturbing the routine, it is creating complications and family issues. So how is it that the government, why are they not that much interested in working on palliative care?
There is a gap between the professionals and the government
Policy
makers. So that which is the main reason in India we are not able to achieve what we are from preparing or planning the objectives, because they are all working independently, they are not coming together. That's what the gap I can see, sir. And if you just see, we also should take initiative, thinking that it will not happen, instead of considering that what a drop I can do to make a ocean. So we can join together like what we are all doing, integrate ourselves and show to the government that this can happen, and this is what, because they are not aware about what is going on. When I was approaching the district officer for my project for lymphedema, that I wanted to go and do the home care service, they didn't object. In fact, they were very supportive. So I feel that they are thinking that we are not going to them, and we are thinking that they are not helping us. So this is what the gap I feel, and if we are working together, I think that we can make wonders for the patients.
Rightly said, and that is where the advocacy comes into picture. So all of you have to be, apart from learning from palliative care is not going to solve the issue. You have to become the advocate, you have to propagate the message, you have to reach the community, make them aware that your sufferings can be treated, your pain can be treated, and you have to approach the government also that how this pain has to be treated by establishment of pain clinics in government hospitals, by availability of oral morphine in government hospitals. It is very sad that in India, in 2014, we had amended the Narcotic Drugs and Psychotropic Substances Act. I was also one of the members who advocated for this amendment, and we discussed in North Block along with other stakeholders. The central government was good enough to amend this act, but again, when it comes to state governments, it is not being implemented. So you are our representatives. You have to go to the state governments and ask them, educate them about the amended NDPS Act, because still there is phobia. Because it was having harsh punishments for keeping oral morphine. The licensing process was very, very difficult, and there were drastic punishments also. But all that has been removed, and we have a new act and which needs to be sensitized. So availability of essential narcotic drugs is again very important. They should be made available in government hospitals so as to treat the pain of the patients. So advocacy again comes into picture. So would you like to share your experience on the burnout, Mr. Menon?
Burnout, when we teach the students, we generally say that burnout should not be there in their interaction with the patient. But what happens is that in one way, thinking in one way, We are building a rapport with the patient. Maybe a catalyst between the patient and the carer or the family members. That's a good thing. But this rapport at a time, at a different time, will depress us, because the patient will have a very good rapport interacting with you. Even the doctor becomes a stranger, the volunteer becomes the most important person in the team, and whatever secrets or wishes of the patient, that will be passed on to the volunteer. So the patient is always looking forward to the next visit of the volunteer rather than nurses or doctors. That's what's happening. The real scenario is that. So the problem comes when the patient is about to die. He may have last wishes, for example, which could not be fulfilled so far. So at that point of time, when he says that you have to help me out, I have a wish, which we may not be able to fulfill at that particular point of time. So the patient dies, and then the distress comes to us. So even if we teach the volunteers that there should not be a distress or a burnout, naturally when it comes to us, naturally we will be forced, because we are empathetic towards the situation, empathetic towards the patient and the family members. So we even discarding our own family relations, our work and all that, we just give more importance to the patient. So in that way thinking, even though we say for clarity in the training programs that there should not be a burnout, actually there is a burnout, because we have already entered into a bondage or a very good relation with the patient. And if you are very, very close to a patient, when he passes away, naturally we will have burnout, and we will become sad, at least for a particular duration of the time. After that it will be subsided. That is the natural course of death and bereavement.
So this is the magic of palliative care. A patient who is withdrawn, who is not at all interacting either with his family or anyone, who is not even eating properly, sleeping or doing any household chores properly. Entry of palliative care teams, they motivate the patient, and many a times the same patient who is not interacting with their family starts discussing his issues, his problems, his wishes with the palliative care team. So that is the magic of palliative care. And now the problem is that an outsider knows more about the patient rather than the home
Family members.
and family members. So this is a very tricky situation, because you have to take the family into confidence. And many a times what happens is that when the patients all of a sudden starts improving, now we may get maybe false hope. So getting false hope about the patient that the patient is recovering, no, it is only that his
Temporary, transit.
temporarily he has improved. And the second thing is, we should not give any false hope to the family or the patient, because there may be unfinished assignments which the patient has to complete. So that is why slowly and slowly we come to the patient and start talking about death. So can you throw some light on that?
Yes, sir. So many times we just meet the patients. In the name of caring, we should not neglect what the wishes of the patients are. I have come across patients requesting, when we just take our vehicle from the hospice care, please don't bring it near to my house. I don't want the neighbors to know what I am suffering. So that is also value, the wish we have to take. And at the same time, if they don't want to discuss about that, give respect to that also.
Patient's autonomy is all the more
Important. And whenever they are comfortable, we have to be open to receive that and be cooperative with the family members and the patient. And as a team member, we also can get involved in that and help them out. Now, how do we help them? As a professional, we can think about if they are having a willingness to do organ donation, we can just have, because that may be the will. Many of them are ready to do that because They wanted to see their body to be utilized for 4 or 5 people, which is going to be a big vision for the physically
community.
disabled people. And the family members also will be thinking that yes, the particular loved ones' organs are distributed in so many people, and we can see them, the lost person, through them also. So preparation need not be that you are going to die, get ready. No, it can be the wishes and how we are going to contribute that. That is also matters for this patient.
I would like to add a particular
Incident.
episode. One Tara, that is the name of the patient, she was 35, she is no more. She had a bowel, pain for many years. She was doing menial jobs in the nearby houses. She has her husband who is not capable of doing any hard work, and 2 kids. And over a period of time, she went to the pharmacy and asked for pain relief, tablets for pain relief. So the pharmacy, the medical shop gave her pain relief, this thing. But unfortunately, that did not stop. The pain continued, and the pharmacy, the shopkeeper told her, "You better have a clinical this thing. You just check with somebody else, consult a doctor." And the doctor said, "You will have to take such and such test. You had to undergo certain." So after the test results, he said that you are having some problems. Then only she was able to know that there was some cancer in the abdomen. So it was too late at that time. So what happened? She was taken to one of our palliative care centers for palliation, and the doctor told her over a period of time that there is little hope for you to live longer. This is the situation. Do you have any wish to be accomplished? Then she said, "I do not have a house of my own. I am staying in the what we call Parvada of the husband. He has his father got 6 cents of land, and we volunteers and the team members discussed it with the father of the husband. He agreed to share 3 cents of land. So that part was over. And nearby there was one convent. The father told us, "We will take care of the registration charges, nearly 5,000 rupees or so." So that case was also settled, and her wish was, "Before I die, I should die in my own home." That was the wish. How it could be done? We mobilized the common, the community, the local community, and we designed a small house for her, and we requested many to donate. Even the the mason told that I will come after my doing the daily job free of cost. I will do this. One quarry owner told us, you need give only the transportation charges. We will give the this thing free of charge. Then like that, the whole community stood for her. A small house was constructed, and the Griha Pravesha was done fantastically, and after staying there for 1 week she died. This is palliative care. So even after the bereavement of death of the patient also, we take care of the children for the studies. Even the husband who is not well, we gave him some We Help project. We give 25,000 rupees and took the initial expenses for providing all the provisions free of charges, and later they will have to do it on our condition. So this is not a stop the show. It has to be continued till the whole family comes back to the normal position. That is palliative care. This is a very difficult task, but if the community around us cooperate, it's very easy. This is palliation, and we enjoy doing it. We do things interestingly, not out of any compulsion from the community. This is my experience. I thought of sharing with you. Thank you.
Thank you, Mr. Menon. So I have a question which is very awkward, but again, it is the reality of life. How many of you have planned your death? So, Mr. Menon,
It's very difficult to give you an answer. This planet is a very good planet to live in, and it has got all the essential, comforts and luxuries. How can I go away with it?
yeah, and that is probably with you, with Mala, and with myself. But again, death is the only reality which is going to come.
But we don't know
We
when.
are sure about it, 100% sure.
But we
Whereas
don't know when.
other things we are not sure about, but we are not prepared for it. So talking about death again is very important, and more so when the patient knows that he is going to die in some time. When I am talking to the patient, I simply say that I am talking to you now, but I don't know whether I will be talking to you tomorrow or not. It is not certain. So similarly, you have to accept that death is going to come, whether today, tomorrow, or any time.
It is inevitable.
So why to have distress? We should welcome death. We should finish our task day-to-day basis. We have to assign the priorities that this has to be done in whatever time, so that we do not have any unfinished business. And this is again very important when you are talking about dying patients. Their unfinished businesses may be there, their will may not be there, and again we can ask the patient to have an advanced directive. That means once he is not able to take a decision that whether he should be put on ventilator or aggressive maybe life-saving devices. So advanced directive helps his nominee to take the decision in his absence. Or he can either do it, write it down that I don't need any medical devices when I am dying, no ventilator, no dialysis, nothing, or I can nominate someone to take the decisions when I am not conscious. So that again is very important. So would you like to share something on that?
Yes. You know that nowadays, this everybody is wants to be with in the final stage also with the family members and the relatives, other relatives, because you know that nowadays this death, it is in a single room, in a ventilator or in an ICU. Because you know that in the last moment, everyone will think that I want to see the face of my
Dear and
immediate
dear
relatives, husband or wife or the children or like that. So that but what is happening nowadays, that we are in that ventilator with all these tubes in all orifices, and we cannot talk, we cannot express everything, nothing, and again we cannot at least we cannot. We want to see the face of our immediate relative. So promote the final stage along with the family members, and the palliative care itself promote that type of death in the final part. So we have to encourage that.
So Dr. Babu is saying improve the quality of death and reduce the cost of death. Madam Mala, do you have anything to
Yes, sir.
say on that?
I just recently came across one of a 85-year-old person who was along with he has 4 daughters who has been married, and he lost his wife long back, 35 years back. So now he is feeling the loneliness, and he is feeling who is going to take care of me. But already the 2 daughters are taking care of him, but he was not very comfortable. He wanted to go back to his native, the house what he is owning, because these are all something his daughter's house. So he is telling, if I am going to be along with these 2 daughters, I may not reach my home. So he is trying to do something with the next daughter. So he puts blame and he tells, I wanted to come with you. So the patient will have so many thinking, and we should understand that. And the other daughter found out that there is some reason, all 15 years when that person is with 2 daughters, why he wanted to come to me. Then what happens is, that family has transportation facility, everything. So he tells, I wanted to go to my waiting. So he is taken there. He goes to each and every corner of the house. He tells, I wanted to spend 10 minutes. I wanted to be lying down on this my bed for some time. All this explaining, and he is very happy. Once he finishes that satisfaction, he tells, we can go.
Hmm.
The next week he passes away. What is that he created for the family members? Yes, everyone said that when they used to cry. Your father is gone, and what is this and all. The daughters were so happy. They said, what was there left for my father? We did what we can. We also celebrated his 85th birthday by cutting cake, which he never did. And we brought him when he wanted to see this house. And we spent at least 3 days here. He had a very good death. He was eating and he just lost us.
The final wish.
Was
This
accomplished.
satisfaction, it need not be only for the patients, it is also for the family members.
So message to you. Have you asked the patient about the final wish? Has the family honored the final wish of the patient? Because most of the time the family calls the shot. They do not listen to the patient,
Yes.
and that leaves a distressful dying. We increase the cost of death and the patient is dissatisfied. Is that the type of death which we are looking for? Certainly not. The parental home and the family members are the best companion, and it is the best place to die. Not an ICU where you have machines and machines and people do not know even the last time of breath. So when we are talking about chronically ill patients, remember they are not to be taken to ICUs, emergencies. You have to be prepared to face the death. So, Mr. Menon, facing the death, the final moment comes. How many people or families they prepare for the death of the patient? Is it being done or not?
I have my personal experience. My 95-year-old mother, our mother died peacefully. She had some, aging problem, some mental issues were there, but remember we are 7 in number and I am the only male member in the family. All the other female members are above. So since I happen to be in palliative care, I know what would be almost the last breath of a patient and all that. So during that particular period, I visited my mother, very often, just to ensure that she dies peacefully. She was taken to the nearby palliative care center for the last 2-3 days, and one of our physicians is very close to me, and he said, Radhakrishnan, you better come tomorrow. It's almost time for her to pass. So what I did, instead of putting her in a ventilator or an ICU, I requested all my sisters to come together, and we spent the last hours with her in the palliative care center. There was a hall meant for that, and she breathed her last.
So that is the death which we expect with our family, and that is the most satisfying death. Again, all the religions, they have some protocol for the dying people, but are we trying those protocols? Certainly not. We start those protocols after death of the patient. Why not, if it can be done before the death? So, Dr. Babu, can you?
Yeah, that is the problem. Then when we put the patient in this intensive care unit or ICU or in this ventilator, actually the days are only hours, or even after days, the doctors will declare that the patient died.
Okay.
So we cannot perform the final rites actually. So if we are sure that that is the final time and the last breath he is going to take, put him in his surrounding with his family members. He can look into the eyes of his immediate relatives. That is the best thing we can give to that particular patient or that person.
Saying goodbye in a better way.
Yeah.
So can you add on?
Yes, sir. So I also had a personal experience when one of my family member was on the deathbed. I got a call whether I have to take the person to the hospital. I said, because I was one of the in charge person for that patient, I said, please don't disturb. Because he was suffering for so long. Why you wanted to again put a burden on? Let him be where he wanted to be. And we will send off him in a nice way. Instead of putting into the ICU or wherever it is, regaining his life and then again going on for suffering. I don't think so. If we are having that advocacy for the patient, we can decide and say a very good, nice way of bidding goodbye to
Bidding adieu again is very important, and I recollect my grandfather in 90s when he, maybe in last 1 week, he stopped eating, he was semi-conscious. So we got drip at our home itself. We called all the relatives, they were there for last 4-5 days, and finally we as per the rituals which were to be done for a dying patient, we were ready with everything. The Ganga Jal, then Tulsi, then gold and whatnot. And as soon as he died, all the rituals were completed. But I am not seeing those rituals coming right now, and maybe people are not aware of that. So, as per your religion, you learn about how to face the death, be prepared, and again, do not take the patient in ICU, don't panic, it is going to come. You know it that it is going to come in next few days. Be prepared and face the death. Say adieu to the patient so that you have wonderful memories and you do not feel that I could have done something better to the patient. So that is my message, and let us not hesitate from discussing or talking about death, because that will always leave unfinished businesses which will be most distasteful at the last minute. Any one of you, if you have anything in mind to share again?
A lot of things coming to my mind.
So you can just share in case if you want to say something.
No, it's okay.
So that means we have a take-home message to you. Palliative care is not only improving the quality of life of the patient, but again, it should improve the quality of death. The death
peaceful death.
which is peaceful, at home, with the relatives, and with whatever the last desire of the patient is, it should be followed, and it should be not very costly also. So with this, we are winding up this interview. All the best, and
Best of luck to
best of luck to all of you.
students. Thank you.
Thank you.
Thank you.